Ya estamos. Pero no me sale a mí aquí en el... Bueno, sí. Ah, vale.
Después me dicen para partilhar la pantalla, ¿cierto? Ok, vale.
¿Y la pantalla donde ve la charla? ¿Tengo que abrir el YouTube?
Sí, te ha mandado el...
Ya estamos aquí. Bueno,
Ya,
pues
bueno.
nada. Buenas tardes a todos. Lo primero, bueno, darle la enhorabuena a Luis por estas charlas, que nos ha invitado aquí hoy a un pequeño debate. Yo soy Willy, de Javier Fernández Jara, y soy radiólogo de Cádiz, pero trabajo en Madrid. Y presentaros a la ponente de hoy, que es Diana Afonso, la doctora Diana Afonso, que es una radióloga de Lisboa. Y tenemos con nosotros aquí, aparte de a Luis Cerezal, a otro buen madridista como yo, que es traumatólogo, cirujano traumatólogo, también compañero de Diana en Lisboa. Así que buenas tardes a todos y espero que la presentación va a ser en inglés y luego al final de la charla haremos un pequeño debate. Si queréis esperamos un par de minutos a que sean las 8 y empezamos. Mientras que está llegando la gente. Y somos los fieles de Luis. Ya veo que está aquí Manuela, Javier, un saludo a todos. Diego Lemos, Víctor Cantarero, Alberto Andrés Llorí desde Buenos Aires, Estefano Belisario, Tomás Pascual, Martiñate, Noelia Arévalo, Silvia Martínez, Kif desde Suiza. Y bueno, esperamos si queréis un poquillo más.
Bueno, pues sí, yo creo que en un par de minutos como mucho empezamos. Veo que estamos casi siempre los mismos.
No, somos
los fijos, vienen los argentinos otra vez y saludamos a alguien que se incorpora que estará esperando que hablemos en inglés desde Suiza, supongo, ¿no?
Sí, Benoit Frick, yo lo conozco del Twitter.
Yo también le sigo en el Twitter, sí.
Sí, una cosa muy interesante.
Bueno, pues está también Silvia, un abrazo Silvia, Marta Oñate, Tomás Pascual, Manuela, bueno, estamos entre amigos, ¿eh? Diego Lemos, un abrazo amigo. Víctor, pues nada, yo creo que Diana, presentar simplemente a Diana, yo creo que ya lo has presentado. Diana es es una radióloga portuguesa que todos conocemos, una de las mejores radiólogos musculoesqueléticos hoy en día en Europa y que da unas charlas espectaculares y con la que tengo una buena relación y la verdad que me gustan mucho sus charlas y por eso el invitarla, ¿eh? O sea que antes de nada, muchísimas gracias Diana por estar aquí y por iniciar la serie de charlas en inglés. La otra de las ventajas que tienen los portugueses, aparte de que hacéis bien todo últimamente, menos haber parido a Cristiano Ronaldo, lo habéis hecho todo bien. Ahora habláis todos muy bien inglés y esa es una gran ventaja. Muchas gracias por estar aquí, de verdad. Y cuando digas, Willy, yo me voy.
Venga, empezamos la charla. Diana.
Diana. Ok, voy a empezar. ¿Sí? ¿Me oye? Ok, muchas gracias. Hola, buenas tardes. Muchas gracias, Dr. Luis Cerezal, por la invitación. Me siento muy halagada y esto es lo único que sé hablar en español, por tanto voy a hablar en inglés. So, I'll talk about glenohumeral instability. This will be a short update for this evening. A small introduction to begin with. Oops. Yes. So, a small introduction to begin with. As we all know, we have the glenoid that is flat and the humeral head that is convex. So this difference actually makes the shoulder the most mobile joint in the body, but also the most unstable joint in the body. For the next minutes, we'll look at anatomy and normal variants, and we'll include a brief look at the slabs, and then we'll move to glenohumeral instability, particularly anterior and posterior instability, and particularly in posterior instability, a couple of things have been coming out in the last 2 years, and I'll show that in the end as we see later on. So we'll start with anatomy and normal variants. So I really like this lecture picture. We all know this one from our med school years. And I usually like to show this slide and ask who thinks this is the shoulder joint. And actually, most people tend to raise their hands, and I will mostly agree. However, to be precise, this is not really the shoulder joint, because this is the shoulder joint. The shoulder has actually 4 joints. Besides the glenohumeral joint and the acromioclavicular joint you see in the prior picture, there's also the scapulothoracic joint and the sternoclavicular joint. So these 4 joints are important to realize it because they are important in keeping the shoulder stable. And I find this toy, which is actually a construction backhoe, a good way to understand the upper limb of the shoulder itself, because as you see here, you need the solid base that is the scapulothoracic to keep the glenohumeral in place, to keep it stable, to work it properly, to allow its normal movement to the remaining upper limb, as you've seen here. So this is a good way of looking at the shoulder. And keeping this picture in mind, the glenohumeral, as we know, is stabilized by static and dynamic stabilizers. So the static stabilizers include the labrum and also the biceps anchor and capsule and the glenohumeral ligaments, and also other anatomic bone and articular structures that will hold the shoulder in place at the extreme range of motion. And then we also have the muscles that are active dynamo stabilizers that will provide both function and stability and keep the humeral head in place. And from the interplay between these 2 types of restraints, the statics and dynamic restraints will have a wide range of motion of the joint. But the imbalance of these stabilizers may lead to shoulder instability, which is our topic for this evening. So let's look at the labrum first. So the labrum, just like the meniscus in the knee, is fibrocartilage. You can think of the labrum just like a wheel surrounding a tire surrounding a wheel, because the labrum is also surrounding the glenoid. This is how it looks on MRI, and this is how the labrum looks at arthroscopy. Here's the glenoid, here's the labrum, here's the biceps anchor. So always think as a labrum as a tire around the wheel. And the labrum serves as an anchor for some glenohumeral ligaments as well as the long head of the biceps. It will increase circumference and depth, it will increase contact and surface area, and we increase rotational stability of the joint. The labrum may have variable size, shape, and signal. Mostly the labrum has a triangular shape, usually on the anterior but also on the posterior labrum, but also can be rounded, mostly on the posterior labrum. This is a nice paper published a couple of years ago, in case if you want to know more about the labrum. Just a quick word for important pitfall, which is the magic angle, usually occurs in the posterior superior labrum, not to be mistaken by a tear. Now, moving on to the capsule, the posterior capsule and the anterior capsule. The posterior capsule has a constant attachment along the margins of the posterior labrum. The anterior capsule, as seen here in these three images, it may be one of 3 types. Type 1, which is this one, that occurs at or very near the labrum, or type 2, that will occur up to 1 centimeter from the labrum And type 3, which is this one, that the insertion of the capsule is far from the label, more than 1 centimeter. And type 3 is often seen in patients with solid instability. That is, it may predispose to instability or can be the result of instability. But also, we need to know that it happens too in patients with absolutely no instability. And then we have the glenohumeral ligaments. The glenohumeral ligaments are basically thick enfoldings of the capsule and will help to prevent anterior-inferior dislocation. We are usually familiar with type 1, which is the classical pattern, which is having 3 ligaments: the superior glenohumeral ligament, the middle glenohumeral ligament, and the inferior glenohumeral ligament. But also, this may be variable too. We can have a type 2, which is having a middle glenohumeral ligament, cord-like, thickened. It's a pseudo-buffer because the level is there, it's not gone. But we also can have a type 3, which is this one, where the middle and inferior glenohumeral ligament are cord-like. And again, another pseudo-buffer. Or more rarely, you can have this, which is type 4, which is having no glenohumeral ligaments at all, which is rare. And then, how do we find these ligaments? Well, the superior glenohumeral ligament is the most constant one. It's the one is present in the majority of the population. Is usually well seen in parallel to the coracoid. So you can pick it up an axial slice on MRI. Just find the tip of the coracoid that's in here, and you'll see this structure lying here. This is the biceps. This would be the superior glenohumeral ligament lying just anteriorly to the biceps here. So it's easy. Pick always the slice on the tip of the coracoid. And some authors don't call it a ligament, call it a complex. And because there are other reinforcements like the coracohumeral ligaments, the coracoglenoid ligament, and the posterior superior glenohumeral ligament posteriorly. But to be honest, it's here. Who wants to know more? There's a good paper here to read. But for the time being, I'll just skip it. And then we'll move on to the middle glenohumeral ligament. This is more variable. I mean, it's absent in up to 30% of the population, has an oblique orientation. And how do we see it on MRI? It's easy. Just pick the axial and the sagittal slice. Here in the axial, a couple of slices lower than this one. So now on the inferior border of the coracoid, you'll find the structure here between the anterior labrum and the subscapularis. And here on the sagittals, this is the subscapularis, and this structure lying here, this oblique structure, is the middle glenohumeral ligament. So it's kind of easy. And then we have the most important one, which is the inferior glenohumeral ligament or complex. So basically, it has an anterior band seen here between 2 and 4 o'clock, which is thicker on the axial plane. And here behind, you have a posterior band, which is usually thinner, usually between 7 and 9 o'clock. And on the coronals, you can see the axillary pouch pretty well. This is a pouch that is in between the anterior and posterior bands. And you also have a recently described ligament, which is called the spiral ligament of fasciculum obliquus, that reinforces this complex. This goes from the anterior-inferior glenoid rim to the lesser tuberosity in a spiral pattern. That's why it's called spiral. But to be honest, it's very hard to see, and its clinical importance is not known, so I don't really care. So now let's move on to the variants. When we think of variants, we are talking about the anterior superior quadrants. Most of the level variants do occur between noon or 11 o'clock to 3 o'clock. Don't forget this. This is the quadrants of the variance. It's also important to always speak the same language as your surgeon. So don't forget the shoulder, just like the hip, 3 o'clock is considered anterior and noon is always superior. Now let's move on to the variance. We'll start with the sublabral foramen or holes, as seen here, is like a focal detachment of the anterior labrum that usually goes between noon and 3 o'clock, usually at 2 o'clock. It should never go below 3 o'clock, should stop at 3 o'clock. It's basically a smooth hole on the anterior labrum. Then another variance, the Buford components, can be seen up to 3 to 6% of the population. It's basically a thick cord-like middle glenohumeral ligament without any labrum in the anterior quadrant, as seen here. This is a thickened middle cord-like ligament, and here is absolutely no labrum. So this is not pattern type 2 that I've talked about. This is because the labrum is gone. So it's easy to get the difference between both. And then we have the most common one, which is the sublabral recess that occurs usually between 1 o'clock to noon, maximum to 11 o'clock. So this is basically a sulcus between the capsulolabral complex and the glenoid cartilage at the left and at the biceps orange. So basically, how do you look? How do you look for it on MRI? Just pick the coronals, and you find at the noon this small recess, and this would be the sublabral recess. Beware that it often may extend a little bit below, but most often it quizzes with the foramen, sublabral foramen. And we can have 3 types of sublabral recess. You can have a type 1, which is having no recess at all. We can have type 2, which is having a small recess. And we can have a type 3, which is having a large sublabral recess, meniscoid type. And in older days, it was said that sublabral recess did not extend posterior to the biceps oranges. Otherwise, a slap lesion would be suspected. However, we now know today that this variant can extend posteriorly to the biceps orange to 11 o'clock. So the big question here is how to tell a sublabral recess from a slap tear. Actually, the answer is that this is sometimes not easy, that is often not easy, sometimes even impossible. But here are some helpful tips. So if you have like this, a high signal that going medial at the labral condyle junction, so goes into, you might think of sublabral recess. The sublabral recess also usually has smooth margins, as seen here, and the recess is usually 2 or less millimeters width, and usually never goes, it usually stops at noon, maximum 11 o'clock, never below, never posterior than that. And for the slap, as seen here, this is in the opposite, the high signal goes in the opposite way, usually goes away. So it goes laterally at the labral condyle junction, and the margins are usually more irregular, as seen here. The recess might be wider, 3 or more, and of course, since a slap lesion can go way posteriorly than 11 o'clock or below 3 o'clock, and of course, the presence of a paralabral cyst would favor a slap tear. So, speaking of which, a slap tear is a tear of the superior labrum, usually centered at the biceps orange, and it can extend anteriorly and it can extend to the anterior posterior labrum. Normal variants may predispose to slap, even though a slap is not a normal variance. Beware that both, for instance, the Beaufort complex or a recess might predispose to SLAPs. SLAPs may involve surrounding structures, and in half of the patients with SLAP tears will be associated to a cuff tear. So, as we know, Schneider, a long time ago, first introduced the term SLAP lesions. They described 4 types of SLAP lesions, but the classification was later extended. In fact, I've lost my mind of my count of how many SLAP types of tears there are and have been described so far. And to be honest, I don't really care. So we'll take a look at the first 4 types of SLAP tear. They are the most common ones, the most important ones. So we'll start with SLAP type 1. So basically what we see an irregularity of the labrum, genitive framing of the labrum with no obvious tear, and the bicep is intact. This is usually age-related genitive change, and in younger patients can be seen with repetitive microtrauma from overhead arm motion. And then we have type 2 SLAP, which involves the stripping of the frayed superior labrum and the attachment of the bicep. This is the most common SLAP lesion and usually associated with microtrauma or overuse injuries. And then we have type 3 lesion, which is basically a bucket handle tear of the superior labrum with the central portion of the tear displaced into the joint, just like a bucket handle tear of the knee meniscus, and will not involve the biceps orange. This is usually traumatic, just like a SLAP number 4, that is very much similar like SLAP type 3, but it will involve the biceps orange, which is also torn. So there are many other described SLAP tears, but as I said before, I don't care because there's great variability in MRI and arthroscopic classifications of SLAP lesions, even among experts. So why do I care for a number? Just go the easier way. Instead of assigning a SLAP tear classification or a number, just describe what the surgeon really needs. And what does he need? He needs you to look at the labrum, see if it has a tear or entire displacement, and localize the lesion. Is it anterior? Is it goes posteriorly? Look then at the biceps anchored and see if it's intact or not, and look for associated lesions like cuff lesions, rotator interval pulley lesions, glenohumeral ligaments, and chondral damage. SLAP tears are not directly associated with glenohumeral instability, but are often found together with lesions related to instability and microinstability. And indirectly, SLAP lesions can actually contribute to ventral instability due to the breakdown of the stabilizing effect of the biceps, as I mentioned before. And now we've talked about anatomy, we talk about normal variants, we briefly look at SLAPs, and now we'll move to pathology, that is to glenohumeral instability. So, rule of life, before you classify a lesion, you need to define it first. And as you see here on this list, even among top-of-the-line experts of the shoulder surgeon, there are variations in definition. So I pretty like this one, which is old definition from J.P. Warner's. It's simple and good, and it works. So basically, this definition, what does it say? It states that, first of all, glenohumeral instability is a clinical diagnosis, not an imaging definition. It's a clinical diagnosis. It's an ability to maintain the humeral head centered in the glenoid fossa during the arc of movement that will lead to symptoms or reduced shoulder function. This is the definition of glenohumeral instability. And now you have a definition, so great, you can classify it. But the problem is that there are too many classifications in the literature. I mean, you can classify instability by grade, by time, by cause, by direction, or you can use Matson's popular acronyms of TUBES or Ambry, or by micro-instability acronyms. Or you can even choose Stanmore classification using polar types that actually seems a pretty good classification, and this goes on. You can also use FEDS classification that uses frequency, etiology, direction, and severity as parameters, and is also said to have a good agreement between readers. So as you might see and imagine, this actually might be a pretty confusing topic. So you can classify it by whatever you almost want. So my usually advice, make it simple. Make it simple. For me, what I've learned from my surgeons is that there are two types of instability: major instability and minor instability. So major instability usually have an history of dislocation, usually traumatic of the first episode, with evident clinical complaints and structural damage to the stabilizers. It may need surgery. On the opposite side, there is minor stability. Minor stability does not imply dislocation, does not imply total loss of articular congruency, but there is inability to maintain the humeral head centered with minor clinical complaints. So basically, there's no trauma and no major structural damage, just some subtle changes in the static stabilizers, like, for instance, some kind of laxity of capsular redundancy, some labral leukoplasia, some mild dysplasia, but these small changes in the static stabilizers are still balanced by the dynamic stabilizers, so medical treatment is always tried first. So this is actually an easy way to understand what we are talking about. So we know now what glenoinstability is, so the question is how to report. It's important for us as radiologists to know what to look for and what to report on imaging studies. So always evaluate the static stabilizers, the labrum, the capsule ligaments, and the potential associated lesions like the bicep, the rotator interval, the cuff. Also look at the bone morphology and look for bony defects, both of the humerus and the glenoid. We need to specify them, to localize them, to quantify them, and look for other bone abnormality, like, for instance, glenodysplasia, or do you see any fragments, any loose bodies? So this is important to tell in an imaging report. Now, as we all know, we have two main forms of instability: anterior and posterior instability. Anterior instability is the most common one, is the one we deal more often, and we can have both bone and soft tissue findings. So regarding the soft tissue lesions at the glenoid, they can broadly be divided into two categories. We have the Banker lesion. This is when we have a torn glenoid periosteum, so there will be a greater displacement of the labrum, and this may lead to a more difficult arthroscopic labral repair. On the opposite side, we have the Banker variants, those where the glenoid periosteum may be avulsed or irregular, but is continuous, is intact. And anterior, these ones, these Banker variants, may be repaired more easily. Recently, the discussion points on instability have swung from soft tissue to bones. The soft tissue findings in the recurrent instability are well known and do not impact treatment strategies as much as bony defects do. And bony defects we are talking about Bankard lesions, Ilsak's lesion, or in older patients, greater tuberosity fractures. So we'll start with the soft tissue findings, and we'll start with the classic Bankart. We'll know this one. So basically, we are talking about detachment of the anterior labrum and an associated disruption of the scapular periosteum. And since this is a Spanish YouTube channel, I brought this nice paper from a Spanish colleague that he published 3 years ago, Luis Santiago from Granada, that has beautiful drawings in here. So here, as I told, there's a detachment of the labrum with disruption of the periosteum. The periosteum is gone, and the labrum actually can stay in place or migrate into the joint. The detached labrum may actually float upward in the joint and produce what they used to call before a GLOM, which stands for glenoid labrum ovoid mass. I don't care for the acronym, but the only importance of this is this may be confused and mistaken by a loose body, but it's not. It's just a migrating Bankart. And as we all know, the classic Bankart can go with or without a bony fragment. If there's a bony fragment, it will be called bony Bankarts. And then we have the Bankart variants. So birds, it's not as common, which is basically the anterior-inferior labrum that is detached but not displaced. And like a variant, as I previously said, the periosteum is intact. It may be mildly stripped, mildly irregular, but is intact. That's why it's a variant. And often this lesion is very difficult to see at standard MRI or arterial MRI or even arthroscopic, since the labrum might be in the correct anatomic position. So usually an upward position can be added and is helpful because why? We'll put tension on the anterior band of the epiphyseal ligament, and this will allow to separate the labrum from the glenoid, and it will allow us to see a little bit better this kind of bird's lesion. Another Bankart variant is the ALPSA. It's coined for anterior labrum periosteum sleeve avulsion. So basically, as seen here, this is a detachment from the anterior labrum that goes medial, and the periosteum might be widely lifted or stripped, but again is intact. So basically, an ALPSA looks like a bird's, but is medial along the anteroscapular neck, and again, it may be missed at MRI. And then another variant is the GLAD lesion, that stands for glenoid labrum articular cartilage disruption. So basically, this is a non-displaced tear of the superior anterior-inferior labrum with associated injury to the nearby cartilage. And since there are damage to the cartilage, loose bodies are commonly found. GLAD is actually a rare injury that primarily occurs in athletes, and unlike prior reports, may have an association with instability besides pain. A couple of years ago, GLAD authors usually used to say that it didn't have any relation to instability, but recent reports tell the opposite. Another Bankart variant, we all know this one, is the Hagel, which stands for humeral avulsion of the infraglenoid ligament. And in up to 20%, plain films actually can be useful because you see a fleck of bone. So this would be a bony Hagel. Up to 20% of these lesions have this bony fleck. And Hagel is actually a very important lesion not to be missed on MRI because it has a higher recurrence rate if not repaired. In fact, it's an indication for possible open surgical repair, and the surgeon really needs to know if there's a Hagel or not. It says to be present around 10% of antral dislocation, but in fact, this might be highly underestimated, possibly because these kind of lesions might be obscured by scarring. And how do we look for them on MRI? It's easy. On the coronal plane, just pick this slice. So instead of the U-shaped axillary recess, you don't see this normal U-shaped recess anymore. You see more like a J-shaped recess. So basically, the normal insertion is gone. So you have a J-shaped axillary recess on the coronals. But you can also look for it on the axials. You can see a way irregular infraglenular ligament will not attach to the humeral side. So these lesions are also important because they are usually associated with subscapularis and also with some bicep tears. So always look at these associated lesions when you look for an angle. And also there are other related lesions. You have agado, which is a rare lesion, which stands for glenoid, the avulsion of the infraglenular ligament. And even more rare lesion is the gaggle and the haggle together. They combine together, and basically the infraglenular ligament is floating. And now, how about bone defects? Bony Bankards, as we all know, is a fracture of the anterior glenoid rim, and is present up to half of patients with recurrent dislocation. And this paper I show here, this is a classic paper, and it showed that the majority of patients with anterior instability had some bone loss anteriorly. And when the glenoid looked like an inverted spear, this actually was an indicator of significant amount of bone loss, at least 25% of the width of the infraglenoid. So traditionally, one defect, more than 20 to 25%, was considered critical bone loss. More recently, this historical critical bone loss cutoff has been questioned. For instance, these two papers, one from 2015, they found out in a high active population of bone loss as small as 14%, patients actually would have more recurrent instability and worse functional results. And this one here from last year, March last year, again, he states that the current bone loss measurements are unable to provide an accurate estimation on the actual biomechanic effect of the glenoid defects. But in fact, despite these results, we need actually more studies in order to clarify it. So traditionally, and for the time being, we'll keep the defect with more than 20-25% as the critical bone loss, and the one that will represent a shoulder that is biomechanic, highly unstable. So we'll need to quantify the amount of bone loss. So that means we need to measure. Now, how do we measure? Well, there are several used methods for calculating glenoid bone loss. You can look it up in the literature. You have, for instance, these three methods. You have Sugaya method, Griffith method, Tickle method. They are all valid. Just pick the one you like better. For me, I usually go the easier way, and the way I do is like this. I usually pick up a sagittal plane, both from CT or MRI. Then I draw a circle around the infraglenoid. Then I measure the whole diameter of the circle, and then I measure the diameter of the remaining glenoid, and just divide the remaining glenoid by the diameter of the circle, and that's it. So this is easy. Another quick word for the literature is not clear which is the best imaging method for bone loss, whether it's CT, CTA, MRI, MRI is in here. So my personal advice is to choose the one you feel more comfortable and is more employed in your country. Now let's move to humeral defects. Well, ill sacs, we know this one also very well. This is basically a posterolateral humeral head compression fraction. Is usually located at or above the coracoid process in the top 2 centimeters of the humeral head. And it's important not to be confused nor by vessels, nor by cysts lying in the bare bone area, nor with the normal anatomic groove that lies posterolateral below the top 2 centimeters of the humeral head. And this is important because it will not be ill sac. It's just a normal anatomic groove that lies below the top 2 centimeters. And these ill sacs are commonly seen in patients with recurrent dislocation, and not so common, there also occurs with first dislocation. And if they're big enough, they will actually engage the glenoid. So this is why size matters. But it's not only size that matters. Location, orientation of the ill sacs is also crucial. So keeping this in mind, that far medial, deep and larger defects are way more critical than lateral, shallower or smaller defects. So besides size, location also matters. And how do we measure this? Well, you can measure the ill sac actually by choosing a nice cut on MRI. And what you do is mapping the width of the ill sacs going medial to lateral. And here on MRI, you will also be able to measure this, which is a line that goes to the cuff attachment, which is called bone bridge. So the bone bridge is important to measure because it will account for how medial the position of the ill sacs lesion is. So the ill sacs lesion, the width and the bone bridge will actually constitute what we call the ill sacs interval. Plus, you can tell your orthopedic surgeon the depth and the height of the ill sacs that he will surely appreciate too. And this takes us to the concept of bipolar bone loss. The concept of bipolar bone loss was a game changer in the way we look at anterior instability. This concept actually underlines that ill sacs lesion is only clinically relevant if it engaged on the anterior glenoid rim in the sports position, meaning maximal abduction, external rotation. And so, from now on, from this concept, the big question would be to engage or not to engage. The introduction of the glenoid tract theory by Yakamoto and his team underlined the importance of simultaneous evaluation of the bony injuries and the possible engagement. So the glenoid tract is defined as the contact area between the humeral head and the glenoid in the sports position. And it comprises approximately around 83% of the glenoid width. So basically, in other words, the glenoid tract will predict the humeral engagement. This may seem difficult, but it's not difficult at all. And this actually is a nice paper from Greece that helps us to understand this concept. So if an ill sac seen here is located, imagine this is the ill sac, and this is the glenoid tract. So if the ill sac is located within the tract, meaning the ill sac is less than the glenoid tract, this will result in a decreased risk of engagement and instability. So we could tell on our report, this would be an on-track lesion. However, if the ill sac as seen here extends beyond the medial margin of the tract, meaning the ill sac is greater than the glenoid tract, so this would lead to increased risk of engagement and stability. So this would be an off-track lesion. So how to quantify bipolar bone loss in daily practice based on all this theory, on these concepts? Well, again, we already know how how to calculate the LSAC. The LSAC interval, I've shown this before, just some images from the same paper. Again, you measure the width of the LSACs and the bone bridge. These two together will be the LSAC interval. And now you have to measure the glenoid tract. Remember, the definition of glenoid tract is the contact area between the humeral head and the glenoid during the sports position. And I told it was about 83% of the glenoid width. As such, to measure the glenoid tract, you just have to put a circle around the glenoid, and then just have to figure out which is the whole diameter that's in here. And you'll have to measure, and you have to multiply this whole diameter of the glenoid by 0.3, which is the magic number here. And then, after multiplying these, you'll have just to figure out which is the anterior bone loss. And then you'll have to subtract. So again, 8.3 is our magic number. Find the whole diameter of the circle, find the anterior bone loss, and just multiply the whole diameter by 0.83 and then subtract the anterior bone loss. And then you'll have two measurements. You'll have the glenoid tract and the LSAC interval. You just have now to find which one is smaller or larger. This is another example. So here, the LSAC interval, this thing here is 23. And the glenoid tract, I measured the whole diameter, I multiplied, and then I subtracted by the anterior bone loss. And I got a glenoid tract of 17. And the LSAC is larger than the glenoid tract. So this means actually, this would be an off-track lesion as I previously explained. So meaning there's an increased risk of clinical engagement. And here, hope no doubts about it. So this is clearly an off-track lesion, and hopefully everyone can get this right. So why does size matter? Why I'm measuring all this? It's easy because it will help the surgeon to pick the treatment for the patient. I know there are many radiologists that don't like to measure. Dr. Rizal has mentioned it before, but I believe that the shoulder, just like the hip, measurements can be actually useful. And here, for instance, as you've seen here on this table, if you have no critical glenoid, no critical bone glenoid loss, so basically your glenoid defect is small and the LSAC is on track, all you need will be an arthroscopic Bankart. But see, if you have no critical bone loss, but the LSAC is off track, you need to add the replissage to the LSAC, or your surgeon, better saying. However, if the critical bone loss is more than 25% of, that is, there is critical bone loss, but the LSAC is on track, a Latarjet will be actually done. However, if there's critical bone loss and the LSAC is off track, he'll lose everything he can to address both defects. So this is why it's important to measure. Before changing topic, just a quick highlight to often forgetting lesions in anterior stability. The older patients, they can also have greater tuberosity fractures and cuff tears, often on the supraspinatus and subscapularis associated with anterior dislocation. So don't forget this as a sign of anterior dislocation, mainly in patients with more than 14 years old, not so older than that. And also a quick word for axillary nerve injury is also a well-recognized complication of glenohumeral dislocation. Often a low-grade injury will progress to full recovery without any kind of intervention. That's always good to know. And then we'll move on to postural instability. Well, it's not as frequent as anterior stability, and lucky for us, it will behave the same way with both bone and soft tissue lesion, except in a reversed way. So in clinical practice, we usually find recurrent posterior subluxation more often than acute posterior dislocation. And there are some recognized risk factors associated with posterior shoulder instability. For instance, retroversion. A retroversion of 15 degrees or more have a higher risk for chronic posterior instability, and you can measure it on MRI and CT easily. How do you do that? It's easy. Just pick an axial plane, usually at the mid-level of the glenoid. Then let's draw a 90 degrees angle all along the axis of the scapular body, as seen here. And then we'll draw another line, just following the orientation of the glenoid joint line, as seen here. And this angle will be our glenoid version angle. Another factor that might be overlooked is postural humeral translation, is when the humeral head, as seen here, is not well centered at the glenoid, but slightly posterior subluxation. And also, the morphology of the posterior rim of the glenoid, it all may influence posterior instability, as seen here. You usually have three types described: normal shape or posterior rim, which is pointed like this here. But you also can have these two variants here, which is a lazy J, which is basically a rounded posterior bone deficiency. And you can have also this, which is called delta variants, where you have a triangular deficiency of the posterior rim. And these posterior rim deficiencies are almost universal in patients with recurrent posterior instability, but they are also seen in patients without instability. So again, beware. And the best sign to diagnose a posterior deficiency is actually to have a longitudinal length of more than 12 millimeters of length of this posterior rim deficiency. Now, reverse Banker lesions, they occur in the posterior labrum when the posterior limb is avulsed, when the posterior labrum is gone. And we can find a bony or a soft tissue reverse Banker, as seen here. And don't forget, when you have a paralabral cyst, they are useful hints to the presence of posterolateral tear. Recently, Naka and his team, they found out that we could also talk about critical bone loss in the posterior instability. Yes, just like anterior stability, we have a critical bone loss. So Naka, he found out that the critical bone loss for the posterior rim would be greater than or equal to 20% of the posterior glenoid width, which will lead to a failure of the isolated posterior Banker repair. So we can talk about the critical bone loss of 20% for posterior instability. And we can also have, we almost have a reversed Ilsachs lesion on the anteromedial head. And actually, this is the more frequently lesions in posterior instability. Here, again, same question: to engage or not to engage. Again, we have to measure. So in a very recent study, so from 3 years ago, showed us how to predict the risk of engagement of bipolar bone defects in posterior shoulder instability by measuring what they call the gamma and the delta angle. So how did they do this? How can we do this in clinical practice? So again, pick up the axial slice on your MRI where you can see where the reversed Ilsachs is larger. And in this cut, you'll just again draw the best fitting circle. And now we'll draw the gamma angle that goes from the bicipital groove to the center of the circle, and then it will go to the posterior margin of the reversed Ilsax. This is what they call the gamma angle. And then we'll draw another angle, which is the delta angle. We'll just go again from the posterior margin of the reversed Ilsax to the center of the circle, and then we'll go to the posterior glenoid rim. And this delta angle that described, it represents the degrees that the humeral head can be internally rotated until engagement occurred. And these degrees of the delta angle are actually reduced by 2 degrees per millimeter bone loss at the posterior glenoid rim. Basically, by adding 2 degrees per millimeter of posterior glenoid effect to the gamma angle, we'll be able to identify those lesions that will be prone to engagement, and as such, we'll be able to assist the surgeon in the decision-making process. This might sound confusing, but it's not, again, a practical example for you to understand it better. For instance, imagine that I have a posterior rim defect with 7 millimeters, as seen here, and my gamma angle is 80 degrees. This means that I will have an equivalent reverse Ilsax with the gamma angle of 94, which stands basically for my 80 that I've measured for my gamma angle, and I would add 14. That would be those 2 degrees that are multiplied per millimeter of bone loss. So if I have a 7 millimeter of posterior bone loss, I would multiply by 2 degrees and would be 40. So these two would be the equivalent of the reversed Ilsax. So this theoretically would be a potential engaging reverse Ilsax with higher risk of recurrence, and probably a surgical bone block stabilization procedure would be needed in this example, for instance. And to finish with, we also have the soft tissue lesions. We have guard lesions, which stand for glenoid rim articular default lesion, or in other words, to make it simple, is the reverse glad. It's usually a posterior glenoid lateral tear with involvement of the underlying cartilage, usually between 7 and 9. And again, just like glad and adjustability need, you should look for also for loose bodies. And then you can also find king lesions. There are several types of king lesions described both for MR and arthroscopy. Basically, king lesions are a superficial tear between the posterior infralabral and the cartilage without any complete detachment of the labrum. So in other words, think of it like a marginal crack or a cyst at the chondrolabral junction. It's often very difficult to tell at conventional MRI, but in arthro MRI, you can see a thin collection of contrast entering a cleft between posterior infraglenoid and the labrum. And then you also have POLPSA lesion. That stands for reverse ALPSA. Is when the posterior periosteum is partially avulsed and the labrum is medial displaced. And again, you can also have lesions of the posterior band of the infraglenoid, as seen here. This is a posterior gaggle where the glenoid insertion of the posterior band of the infraglenoid ligament is gone, but you can also have reversed haggles too. You can also have cuff tears. In fact, it's more common to have cuff tears in posterior instability and anterior stability. You also can have postural capsule redundancy. So it's very similar, but in the reverse way, the soft tissue findings as anterior stability, just like a mirror. So finally, after this long talk, some take-home points. One needs to recognize normal anatomy. one needs to recognize normal variants. One needs to understand glandular instability, need to describe the stabilizers involved, look at the bone, look at the soft tissue stabilizers. And regarding bony defects, you have to look at both at the glenoid and humerals. It's important for you to specify, to localize, to quantify these defects. Don't forget, in instability, you need to quantify critical bone loss. Is it larger or not than 20-25%? And measure the heel sex interval, and also the gamoid tract. With that, you can see on a report if it's an on-track or off-track lesion. And on posterior instability, again, look for bony defects, locate them, quantify them. We already know there's a critical glenoid bone loss for posterior instability, 20%. And the gamma angle has been very recently described. Probably it's and our shoulder surgeons aren't familiar with this one, but may be useful in the near future. And finally, any associated chondral biceps foley or cuff lesion should be also reported. This is my final slide. This is a picture from my hometown, Madeira Island, that is now locked down with this pandemic state. And don't forget, tough times don't last, but tough people and teams too. Muchas gracias. Thank you. Yes.
Ya está, muchas gracias, Diana. Un placer. ¿Dónde está el que coordina el debate? ¿El de Jerez? ¿El de Jerez?
Aquí.
Ah.
¿Se me ve o no? Bueno, muchas gracias. Thank you very much, Diana, for the presentation. And is there any questions? Or maybe I can just do questions about the technique. Your personal opinion. What do you prefer for the diagnosis of shoulder instability? If you prefer MRI or arthro MRI or arthro CT. The second question about the technique is, do you think it's interesting to do at the same time arthro MRI and arthro CT? And the last question is, what do you prefer for post-surgical studies? 3 questions about technique.
3 questions. Let me one at each time. So the first question, MRI and arthro MRI. Well, this is an easy one, and I mean, if you are dealing in an acute setting where you probably still have fluid inside, I think it's reasonable to proceed with a conventional MRI. Even if you're dealing with elite players, if you have effusion, so it's safe, it's fast, so you can go MRI first, but it's fast, it's safer, it's cheaper. But of course, if you're not dealing with an acute setting, meaning probably you don't have fluid in the joint anymore, so you don't have any distension, so you'll probably need an arthro MRI. Arthro MRI, in the place that I work, is the #1 procedure, mainly if we're dealing with elite soccer players, and it's the best for looking at labrum and capsule ligaments, so no doubts about it. Regarding arthro, the second question would be MRI and CTA, right, Willie?
Both at the same time. As arthro MRI and arthro CT.
Well, depends. Well, that's a very that's a question that can lead us into this question, the discussion, because it depends where you live at. Because if we're in France, probably they'll do it an arthro scan immediately because it's cheaper. It depends of if you're dealing with private practice or not, because of reimbursement of insurance. I personally, my favorite method, and from the literature, is clearly arthro MRI. I mean, no doubts about it. CTA, I look at CTA as a good backup plan, for patients that cannot perform MRI, and for instance also pretty good for instance when you have a bone loss or cartilage loss and you want to find also loose bodies there. Probably the CTA, the arthro CT is better, but I look at arthro CT as only as a backup plan when we cannot perform, when the arthro MRI cannot be performed by intolerance, by claustrophobia, etc. So, so replying to the first two questions, I think MRI is the right answer to go. In the place that I work for private practice. We don't do CTA and combine with MRI because of pricing, and that's, I think it's how do you say this in English? I think it's same information taken from two studies, and we are radiating. These patients are usually young, why to radiate where MRI is pretty good. Only if the patient cannot stand the MRI, there's two artifacts you can proceed with the CTA, I think so. And regarding the third question, I think would be pause up, right? I cannot hear you. Willy, I'm not hearing you.
Willy, no te oímos.
Ah.
Estás desactivado, Willy.
Okay. Now? Do you hear me?
Yes, now.
Okay, regarding the second question, in my opinion, I think it's in the setting of a person that is in the clinical scenario of a dislocation, of a trauma, I think it's interesting to do both CTA and arthro-MRI, because sometimes you can miss the bone defects in the arthro-MRI and bony fragments.
But with these new sequences, these new 3D sequence, I mean, I think we are pretty good, and the papers say it's looking at bony defects with MRI and with the arthro MRI too. So,
Can I join?
of course.
Yeah, the question with the CT scan, I agree with Diana, and I also agree with you, Willy. But the thing is, as a surgeon, I need to know what to do with that bony defect. And the arthro MRI does not allow me to assess adequately the size and the shape and the number of fragments that I have in order to plan my surgery adequately. So the CT is much better. I don't need an arthro CT for that. I just need a CT. So sometimes I think the arthro MRI is for sure the exam to use when you're evaluating shoulder instability, because most of the times, which is quite normal, I would say, you have labral injuries without bone loss. Not talking about bone loss, just labral injuries that extend beyond the anterior region, even if you had an anterior shoulder dislocation. So when you're planning a surgery, and in the private setting, you have to tell, well, I'm going to use probably 2 anchors or 4 anchors or 6 anchors, or you have to manage patients' expectations. It's different when you tell them, well, you have a panlabral tear, which goes from, I would say, 3 o'clock until 11 o'clock. Then when you have like just a 3 to 6 o'clock lesion. So for that, the arthro MRI is for sure the best exam. But when you have bone loss, you need to know what you're going to do. You need to know if you need to do a lot of J. You need to do if you can. You need to know if you can fix the bone loss with anchors. You need to know if you can fix it with screws, because there are different sizes and different shapes of the bone losses or the bone injuries. I'm sorry, not just bone loss, but bone injuries, because not all bone injuries are bone losses. Sometimes just a glenoid fracture that you can address either arthroscopically or open. And for that, for sure, for me, the CT without contrast is the best exam.
Yep, that's right. That's why I say do it both at the same time, because sometimes some surgeons order us a CT after doing an arthro MRI, as you said, before surgery. So that's why
Yeah.
it could be nice to do an arthro MRI and a CTA before surgery.
But for instance, it's not Carlos is favoring the arthro MRI and a normal CT.
I know, without contrast. Yeah, but
Without
if you,
contrast.
yeah. But if you do both, you can take off the contrast and do a CT and see the bone defect.
Yeah. But for me, to evaluate bone, CT for sure. I've had some surprises with MRI when evaluating bone. I mean, you can assess the size of the defect, but you cannot assess the shape and the dimension of the fracture. I don't know if I'm making myself clear. So you can look at the glenoid and see, well, there's something missing here, but when you try to evaluate the part that's missing, you cannot do it. And there's another thing. CT allows you to evaluate things in a 3D way. And that's very helpful when you're planning surgery. When you're planning your approach and say, well, I could probably manage this with arthroscope, or I'm for sure I'll have to open this. And can I use screws, or should I just use small stacks? That's CTs. For me, it's better. But it's probably just a personal preference. But it is what it is.
Yep. Okay, perfect. And just the last question about the technique is just, what do you prefer for post-surgical studies?
Well, really, again, the same answer.
Nice.
Well, for, again, MRI, mainly for patients who have undergone capsule label surgery, MRI is the #1 technique. Arthro MRI.
Arthro MRI. Okay.
Arthro MRI, yeah.
And when do you have lateral jet procedure?
Oh, well, they usually ask for a CT.
CT.
A CT, right, Carlos? Carlos can.
Yeah, for sure. You need to evaluate the position of the graft and see if it's healed, and you can only do that with the CT scan.
Yeah, that's right. Okay, perfect. And then another question. I don't know if maybe we can do some questions from the audience, from the chat, Luis. Let me check. Is Luis there? He's watching the Atletico de Madrid against Liverpool game because now we are the actual Champions League.
I prefer don't talk about soccer, please. Especially with people supporters of Ronaldo. Some questions, for example, the usefulness of our position in instability. I think it's clear that the ABER is essential to diagnose partial articular tears of the supraspinatus, and especially the horizontal extension. But what is your opinion, Diana, the role of our position in instability? And also other dynamic projections, such FADIR and ADIR positions.
The upper position, I think, is a good one to be included in the standard MRI protocol. Sometimes the patients don't collaborate that much, but when you can get a good upper position, it's good. The remaining positions, I'm not. We normally don't proceed it. The internal rotation and with adduction, we usually don't do it. What's your opinion, by the way, Dr. Luis Rizal?
My opinion, I think ABER should be part of our protocol. But I have, in the past, we have a lot of experience to do internal and external rotation. And this is an idea of Maria Teresa Guedes from Venezuela. And we have several awards in RSNA and European meetings, but finally others publish that. But I think it's early useful to do internal and external rotation, especially in non-collaborative patients to do hyperposition.
Hyperposition, yes, it's always included in the protocols. The problem is that when the patients sometimes they don't collaborate, there are some artifacts. The internal rotation, not included in our standard protocol so far.
No, not in the routine protocol because this is impossible. But in selected cases, when you are controlling the study, I think it could be useful.
Yeah.
Not as routine, of course. And other questions, for example, how to differentiate several lab relations? Maybe Carlos agree with my opinion. Most of the types of lab relations has no matter. It's the same to have PERTES and ALSA and Bennett. All the acronyms are treated exactly equal. I think it's very much important to do a precise evaluation of bone defects than to precise the acronym, because a PERTES and a banker for a surgeon could be the same treatment. Is true or is not true?
Yeah, I don't think the acronym is the key. I think that the most important thing that when differentiating from a Bankart or a PERT or an ALPSA, sometimes is the severity of the injury. So if you have an ALPSA lesion, you know that when you're doing the Bankart repair or the simple reattachment of the labrum, you have a higher percentage of recurrence of instability than if you have only a simple Bankart lesion. That's because of the detachment and the elongation of the capsule itself. And another thing that changes is also the technique. Well, actually, it doesn't change, because if you're doing a proper repair of a Bankart lesion, you always have to detach the capsule from the glenoid. So you need to detach it, see the subscapularis, and then reattach it again, like you're just tying an hammock to the tree. So from the point of view of technique, it shouldn't change. From the point of view of patient expectation and level of recurrence, it might change. The artery MRI is really important because sometimes you have some capsular tears that are not seen with normal MRI, and that should also make us change a little bit our the way we do things, because capsular injuries, along with labral injuries, they're probably more difficult to address arthroscopically, and the results are not that good. So if you have like 3 or 4 or 5 shoulder dislocations, it's probable that not only you have some bone loss from erosion. It's not a traumatic bone loss. It's a micro-traumatic bone loss with some erosion. There's there's not a regular shaped glenoid, just like more round one, and also the capsule might have been injured. So in those cases, it doesn't matter if it's a PERT or if it's an ALPS or if it's a Bankart repair. What matters is that gives you a sense that soft tissue is not good enough for you to do a normal soft tissue repair. So I would agree with you, for sure.
There are a lot of variants of the capsule and ligaments. And Diana, do you have experience with these variants are related to instability? Some of these variants are related to instability.
Which normal variants? Sorry.
Several variants. For example, anatomic variants of the ligaments are related to predisposing to instability, or?
Well, they have to be somehow, because they are important. They are. We also, when you have instability patient, we also have damage of the glenohumeral ligaments. So they're important static stabilizers. So they have to.
it also depends on the definition of instability. So if you define minor instability as the inability to center the glenohumeral head without a major anatomic defect, you might get some surprises when you do an MRI of those patients. You just have a capsular redundancy. When we talk about multi-directional instability, sometimes you just have redundant capsules and that's it. And it's not a defect. It's something of their own.
Okay. Yes, I think it's really. I think for me it's most important to see the relation with the minor instability or micro instability, because this is a very difficult topic for the surgeon and also for us in the diagnosis.
Yeah.
Yeah.
Creo que hay más preguntas, pero no las veo.
There is another question asking about the chondral defects that they ask about. We call it not so many times on the arthro MRI, and you, Carlos, do you see frequently the arthroscopy?
Yeah, not that. I mean, frequent. You don't see it as much in your exam, but it's quite frequent, I would say, because the labrum is attached to the cartilage, so it's normal when the shoulder dislocates and it just tears the labrum that it might detach a little bit of the cartilage. What you see sometimes also is that the cartilage defect, it's bigger. I mean, you have bone, but you have no cartilage. I think that's the typical GLAD. That's it's not very useful. It's not very common. And from the point of view of surgical treatment, what I've found in the few patients that I've treated with that, and I usually do some microfractures when that defect is big enough after finishing my repair, is that patients usually evolve with more pain than other patients. So again, the thing with the exams is not only to have a diagnosis, is also to manage patients' expectations. So if you see a GLAD injury, you need to advise your patient that probably the result will not be that good over the years. Avilius in his papers where he evaluated patients 25 years without surgical treatment, he saw that the patients with a shoulder dislocation have a higher rate of shoulder arthrosis than patients that don't have shoulder dislocations. So that's the natural history of shoulder dislocation. And I wonder if that doesn't start with that episode of cartilage damage. It's not just the instability, but also the cartilage damage and all the inflammatory process that derives from there that might lead to that. So that's important to have in mind when evaluating those patients, and also, like I said, to manage patients' expectations.
Okay. And another question for you, Carlos. I'm going to put you in a clinical scenario. Okay, there is a young man that had a history of dislocation, first surgery of banker surgery, and then he has a new dislocations after surgery. So you order an MRI. We tell you that there is almost no labrum. And how do you manage this patient?
Well, I would say that for a recurrent dislocation, even if he has an Ilsax, I would go for a Latarjet, because, like I said, soft tissue is not good. So if you see soft tissue, every material obeys to the same, or I'm not an engineer, but I would say that happens to the same laws of physics. So you have an elastic deformation of the material, and then you have a plastic deformation of the material. That happens also with your shirt. So if you stretch a material to a point where it surpasses its elastic deformation limit, then it gets plastic deformation. And plastic deformation does not recoil. So soft tissue injuries sometimes behave like that. As much as you stretch again the capsule back to its place, it will always be like elongated. So for me, if you have one dislocation and you repair it, then you have 2 or 3 or 4, and everything was done properly. I don't think that my colleagues are incompetent or something, because I have recurrence cases also. I think the problem is mainly soft tissues, and in that case, for me, letter J is the choice. I mean, French guys don't have as many recurrences as we do because they just don't care about soft tissues. You just go there, put the bone block, and it's not about the bone block. It's the effect, the sling effect that the letter J gives us. You know, when you lower the subscap and when you have the conjoint tendon just, you know, stopping the head from going anteriorly. That's the key for the letter J.
Okay, thank you.
You're welcome.
A very difficult question from Ara. The problem to define the capsular redundancy in hematography. Especially it depends a lot, is the opinion of Ara, and is also my experience, that it depends a lot, even the definition of the types of Flatkin capsule, it depends of the volume injected, and also is very depending of the degree of rotation. And for me, it's very important to do the examination in a slight external rotation. But I have no solution to define the capsular redundancy on MRI. What is your opinion, Diana?
Well, if you have not, if you have an artery MRI, if you didn't put too much contrast, no more than 10 to 15 whole volume of contrast inside, and the capsule looks too big, or when you have a conventional MRI, when you still have a bit fluid and the capsule looks a bit redundant, I often call it without any guideline. I mean, it's more like a ball line because there are no standard definition of capsular redundancy, not that I know.
I actually, when I look for redundancy, I look a lot for the rotator interval redundancy. And I also see some indirect signs, like maybe the labrum is more like rounded when there is redundancy. I don't know what you think.
To have a rounded labrum, so that will not help me a lot. To call it redundancy, I like to see mostly the postulated capsule, the one I call it, more bubble-like, more lifted, kind of like.
I think that's why it's important to have the surgeon's information when you do the exam, because if you have adequate information, then you can look for things. So if you have a patient that you suspect minor instability, and you ask the imaging colleague to go and look for it, it's easier for them to say that, well, probably this patient has a capsular redundancy than if you have a traumatic shoulder dislocation. So I think surgeon information is very important.
Yes, and we are often we also overcall things with the information we get from you, but also that's part. I'd rather know information, be a bit biased, and overcall things than not doing it.
Okay. Any more questions from the chat?
A question from Diego Lemos for the surgeon. What do you think of labral reconstruction, not repair, reconstruction, in case where the labrum is not repairable or not present?
I have absolutely no experience, and from my point of view, I do not intend to have, because lateral J procedure is a good, reliable, reproducible procedure with excellent results, and above all, it has resisted to the test of time. So we have a lot of literature, and we have a lot of results from different surgeons, and it's a reliable, reproducible surgery. It's not plan A. It should be plan B for minor glenoid defects, even with Ill-Sachs defects, because they have also Bankart and remplissage. That's another option we can do. You can do a capsulotenodesis of the infraspinatus to the Ill-Sachs, and that increases the chance of stability in shoulders that have that minor glenoid bone defect and also an Ill-Sachs injury. And if it doesn't work, we always have ladder J. So I don't have any experience, and honestly, for those very specific cases, I would just do a ladder J because it's reliable, and I don't want to put my patients to my learning curve. I don't want them to suffer my learning curve.
A question, another question. In post-surgical patients, do you prefer CT arthrography or MR arthrography?
It depends on what I've done to the patients. If I've done a soft tissue procedure, I would go for an arthro MRI.
Of course,
if I need a lot. Sorry.
Of course, when the fail, we have a problem with the surgery. You prefer to do?
Yeah. But if I only did a soft tissue procedure, I would go for arthro MRI. But if I have the smallest amount of metal, or if I need to evaluate bone, I would probably go to the arthro CT. So that's my, for example, if I have a problem with the ladder J, I would not do an arthro MRI. I'll just go and check with the CT. If I have some problem with the soft tissue, I will start, it's the same protocol. I would start with an arthro MRI. If I have doubts about the bone, I would go for the CT. I would never do surgery in a patient without being sure that the bone, that I have adequately characterized the bone. So if I'm not sure about the bone, I always ask for a CT, because sometimes MRI is not that good.
And they also ask about the graft. They say if you use coracoid or tibial graft.
I use coracoid because, like I said, the thing about ladder J is not only the bone. Of course, some patients have a huge bone defect, but the thing with the ladder J, it has a triple effect. It's the bone, it's the sling and the lowering of the subscap, and also if you spare a small 1 centimeter of the coracoacromial ligament, you can do a capsulorrhaphy. So you have all this. You have 3 effects with 1 surgery. So for me, ladder J, it's probably one of the brightest and a game changer in the treatment of instability. And it's so big that honestly, French guys don't do other things. They just do ladder J for all sorts of instability. I've never seen Gilles Walsh talking about Bankart P pairs, and I don't think I ever will. Or Nathan, or it's
actually I work for some surgeons that they perform lateral jet not only in patients with more than 25% bone defect.
Yeah, they do it for all patients.
Yep.
And
Yep.
if you see some of the literature, it's actually curious that when they talk about bone defects, they talk about bone defects and critical bone defects. But if they talk about a collision athlete or of how do you say it, a high-level athlete, they usually go for the ladder J because it's a safe procedure with a smaller risk of recurrence. When I mean smaller risk of recurrence, it will go from 2 to 4% in very inexperienced hands versus a Bankart that can go up to 40% of recurrence. So when you're talking to a patient, you should tell him this. I mean, I have a plan A that it's less invasive, that it has, I would say, it's less risky from the point of view of neurovascular injuries, but from the point of view of recurrence, it's higher. Then I have plan B. Well, plan B, I can use it right now, but if plan A fails, I can also use plan B. So this type of discussion needs to be, you need to perform it with the patient. You need to engage it engage the patient in its own surgical process.
Do you do it arthroscopy lateral jet or open surgery?
No. There's no literature that has convinced me that arthroscopic ladder J offers any advantage over open ladder J. No literature has convinced me of that. If you see the beginning of the arthroscopic lateral J, not only they had failures regarding screw positioning, but they also have neurologic injuries, severe neurologic injuries. And Lafosse reported them. And I don't want, like I said, my patients to go through my learning curve if other surgeons did that by me. So I don't have like 100 lateral J's to perform a year. So if I had, I mean, I could try a couple of them, but I don't think it's good for my patients. And I'm really happy with my open lateral J's patients. It's one of the it's one of the best procedures in shoulder surgery for me. It's I mean, you can think it's very invasive, but when you do things correctly with the correct steps, you put the bone block, and the only thing you have to do is just close the skin, because everything goes into place. You have to do nothing else. It's a beautiful surgery, honestly.
Yep. Thank you.
How to differentiate between capsular strapization of contrast from capsular defect, especially how to differentiate Hagel lesions, humeral avulsion, from an strapization from overdistension. Diana, what's your opinion?
Yeah, that's a nice question. Sometimes it's difficult, but you have to be sure if you put more than enough fluid inside the joint, it will for sure extravasate, and they may mimic a lesion. So I think the best answer to that question is never to exceed, for instance, 15 millimeters in a shoulder joint of contrast. Otherwise, it will extravasate and will mimic a Hagel lesion.
Another question for the surgeon. Nowadays, what is your opinion in slap injuries? Do you perform reparation, anatomy, or it depends of the patient? And where do you do the tenodesis in case of tenodesis of the biceps?
So that's a very tricky question, because the thing is, the name slap injury, that's tricky, because sometimes it's not an injury. Sometimes they're just degenerative changes. And there's a paper from, I believe it's a Norwegian colleague. They evaluated in SLAP 2 patients. They did a prospective randomized controlled study, and they did sham surgery in one of the groups. They did tenodesis in the other one, and they did a repair in the other one. And the best results were achieved in the patients that had no surgery. So for me, I'm getting more and more conservative about SLAP injuries. I would say that in most of them, I would recommend only surgery in young patients. I would do a repair in patients under 25, and always tell them that there is a plan B for a tenodesis if this doesn't work. For patients older than 25, I would say tenodesis seems to show the best results. And in those cases, I do suprapectoral tenodesis, arthroscopic suprapectoral tenodesis, but outside of the gutter, not inside the joint, and not a soft tissue tenodesis. Just drill the biceps groove, 2 anchors, and just repair it arthroscopically. That's my technique. I don't use screws.
And what's your opinion about the tenodesis with the conjoint tendon in the coracoid?
I've never performed it. I've never did it. Never done it. So I have no experience with that.
Okay. Yes. Thank you. More questions? Or I have a very important thing to show you, especially for the Cristiano supporters. No, no voy a poner lo que me apetece. No. De verdad que no. No.
I'm also a footer supporter. Oh.
No. Real Madrid and supporters of Cristiano, no podéis entender esto.
Está sentando
Sí.
encima del macho el confinamiento. Carlos.
Bueno, nada que decir. Mi pasión es Benfica. Mi pasión es Benfica.
There is only one thing, that Fernando scored the goal with the Spanish national team in the European Cup. So,
es eso. Benfica es un equipo que nos engaña cada año, nos vende a jugadores a 80 millones, a 120. Lo único,
Eso es verdad.
me caéis bien porque sois un equipo como nosotros, de poca suerte.
Sí.
Bueno, muchísimas gracias. Muchas gracias. La verdad que ha sido muy, muy bonita la charla. Os lo agradezco mucho, Diana. Un placer, como siempre. Eres una monstrua, en el buen sentido de la palabra, una gran radióloga, una gran
Como
amiga.
anciano.
Y Carlos, un placer conocerte y nada, cuando esto pase estás invitado a Asturias a marisco.
Ah, muchas gracias, eso sí.
Eso seguro que te gusta.
Le elevo una, ¿cómo se llama?
Una servilleta, un babero.
Del Atlético.
Vale. Bueno, si vienes de
Para comer
Cristiano,
marisco, no te preocupes.
el que venga de Cristiano no está invitado a nada. Ni Willy, que ahora me he enterado que es de Jerez.
el sur de Jerez, el sur de Jerez.
Bueno, pues un abrazo. Muchísimas gracias, Willy.
Venga,
Muchas gracias.
gracias.
Y nos vemos otro día. Muchísimas gracias a todos.
Muchas gracias.
Vale,
Hasta luego.
Un abrazo. Seguimos en
hasta
contacto.
luego.